Acute myeloid leukemia is a disease associated with older age, a group which rarely achieves long-term leukemia-free remissions with traditional chemotherapy. In addition, older adults with AML who are unfit for standard chemotherapy have poor outcomes. Fortunately, we've had several recent FDA approvals of novel agents for AML, providing opportunities to individualize therapy for each patient. In this OncLive peer exchange discussion, we will discuss current and emerging strategies for improving remission rates in AML. I am Dr. Harry Erba, professor in the Department of Medicine at the Duke University School of Medicine and member of the Duke Cancer Institute in Durham, North Carolina. Today I'm joined by Dr. Naval Daver, associate professor in the Department of Leukemia at the University of Texas MD Anderson Cancer Center in Houston, Texas. Dr. Rami Kamraji, senior member at the H. Lee Moffitt Cancer Center, specializing in malignant hematology. Dr. Mark Levis, professor of oncology and program leader of the Hematologic Malignancies and Bone Marrow Transplant Program at Johns Hopkins Sidney Kimmel Comprehensive Cancer Center in Baltimore, Maryland. And Dr. Dan Pallier, clinical director of leukemia services and associate professor of medicine at the University of Colorado Cancer Center in Denver, Colorado. Thank you. Let's begin. Mark, I'm going to have you take us through some of your considerations of what kind of testing needs to be done at the time of diagnosis, molecular testing. What are you doing at your institution?
All of them. Mostly, we are getting over the panic that sort of came over us a few years ago when we introduced next-gen sequencing and targeted agents. When a new leukemia patient would show up on the wards, me or the other attendings would freeze. Okay, I've got to do this carefully now. So we actually have evolved a sequential testing strategy based on what we need to know sooner and what we can wait on a bit later. And so certainly we'll, haphazardly say all of them, but in fact it is this sequence. The first thing I want to know after having ruled out APL is, does this patient have a core binding factor? And so that's actually a FISH test. It's the quickest. I mean, you can get RT-PCR or so forth, but in fact, the overnight FISH to rule out core binding factor, because we might introduce gemtuzumab into our induction strategy. The next thing we want to know are two things, and that requires a next generation based sequencing approach, which is TP53. I don't want to start intensive induction therapy on a TP53 mutant patient, but I'm going to get a clue if I sent AML FISH, because I can get a 5 or 7 deletion back within 48 hours, and that's going to give me a clue that maybe this patient is going to be TP53 mutated. They have a high white count, I might be forced to start treatment, although we have data that we can delay, right? Mm-hmm. So I want to know about FLT3, of course. Do they have a FLT3 TKD or a FLT3 ITD mutation? Because I'm going to try and introduce, then I'm really going to go on a normal paradigm of starting 7 and 3 with the thought of adding midostaurin on day 8. So we actually have a rapid turnaround next generation sequencing panel that we can get back in time to get those kinds of results. The FLT3, by the way, is a PCR assay. And we can actually get that within 2 to 3 days, typically. We're not in that much of a hurry. So that's a more rapid turnaround. So kind of actually it's a series of things. Certainly I want conventional karyotyping, but that's going to come back a week or 2 later. That isn't necessarily going to impact induction. I'm going to want to know FLT3. I'm going to want to go core binding factor. I'm going to want to know TP53. The other more broader mutations, like I want to know about IDH, particularly if it's an older patient. Okay, that might influence starting out therapy with azacitidine combined with venetoclax, or I might even consider azacitidine combined with an IDH inhibitor or IDH inhibitor as monotherapy. So we will get next-gen sequencing back with the rapid panel within the week, but it still goes in kind of a sequence.
Yeah. So what I heard you say is that you order everything, but what you need right away is an AML FISH panel looking for core binding factor translocations, chromosome 5 or 7 changes, and those FISH panels have other probes. They might find other deletions or additions that might help you in looking for that complex karyotype, which 75% of the time will have a P53 mutation, or we actually have an approved drug for de novo AML with an MDS-like karyotype, liposomal daunorubin cytarabine, GO for the core binding factors, and a PCR assay for FLT3 and IDH, because you get that back quickly. The next-gen panel, important prognostic information, but that can wait. The karyotype, that can wait, but you order it.
I think it's important also, and I've been stressing this, any change in disease status, the treatment didn't work, okay, reassess. And usually that's a next generation sequencing approach to reassessing. They're not going to come up suddenly with core binding factor out of the blue. But a targetable mutation, a FLT3 might come, a FLT3 might go. And so whenever there's a change in disease status, the patient was refractory, the patient is progressing, the patient has now relapsed, I want to reassess. But again, the emphasis tends to shift more towards next generation sequencing and a FLT3.
So Rami, should next-gen sequencing panels be part of standard of care in AML?
I think so, definitely. I totally agree. I think obviously at the beginning they are very informative, but we do the same. Like whenever there is a change, we'll recheck, because I think that gives you window of opportunity whether to enroll patients on current clinical trials or use some of the agents that we have now. So again, like in FLT3, sometimes you see escape, new mutations coming up. So I think there is value of checking them. Probably we'll touch base at one point also about the value of achieving negative MRD status with the treatments, and that could be partly evaluated by next-gen sequencing as well.
But there's a problem with next generation sequencing making that statement, because what a lot of oncologists don't realize is that diagnostic companies are bundling everything together, and you get your final report, this beautiful, well-written report 2 or 3 weeks later. Oh, by the way, you didn't know about that core binding factor. You didn't know about the FLT3, and you haven't started treatment in time. You didn't consider the fact that there was an IDH mutation. Maybe that patient, the patient's on the border, or they're going to be a good responder to aza-ven. So choosing what you want when, and this turnaround time is still a problem.